بسم الله الرحمن الرحيم. أنا الدكتور أحمد أسامة حسن. محاضرتنا اليوم حتكون about the anus and anal canal. Learning objectives: to understand the anatomy of the anus and anal canal and their relationship to surgical disease and its treatment, to understand the pathology, clinical presentation, investigation, differential diagnosis and treatment of diseases that affect the anus and anal canal, to understand that anal disease is common and its treatments tend to be conservative, although surgery may be required, to understand that any damage to the anus, including too aggressive or inappropriate surgery, may render the patient permanently disabled. This is a cross-section showing the rectum and anal canal. Anal canal is the continuation of the rectum. Embryologically, it is formed through the fusion of the ectodermal proctoderm with the hindgut endoderm at the site which is called the dentate line or pectinate line. From this line, there is a longitudinal mucosal fold extend upwards, which is called the column of Morgagni or the anal column. Between each column, there is a groove which is called the anal sinus. This anal sinus ends downward with what is called the anal valve, through which the anal glands secretes mucin as a lubricant so that it can expel the fecal material through the anal canal with a low minimum of friction to the mucosa of the anal canal. This is the internal sphincter, which is the continuation of the circular smooth muscle of the rectum, the inner layer, while the outer layer, this is the longitudinal muscle fibers. At the end, it gives septation to the nearby structures and to the perineal skin. Here is the external anal sphincter, which is composed of three parts. The upper one is deep, while the other one, the middle, is superficial, and the lower one is subcutaneous. Near to the deep part of the external sphincter, there is a puborectalis muscle, which is the part of the levator ani muscle. It makes a ring around the anorectal junction. It makes as a sling, so that making an anorectal angle, which is about 80 degree, that make the rectum continent state to preserve and maintain the fecal material till to the time of defecation. Nearby structures here, this is the ischioanal fossa, this is the ischiorectal fossa, and this is the supralevator space in the pelvis, and here it is the perineal skin. Here the longitudinal muscle of the rectum descend downwards between the internal sphincter and the external sphincter and give septation to the nearby structures, and here to the perineal skin, which is called the corrugator cutis ani. This is the deep part of the external sphincter, and this is the superficial part, and this is the subcutaneous part. Here is the puborectalis muscle. Clinical applied anatomy. Anal canal is divided according to anatomical anal canal or surgical anal canal. Regarding anatomical anal canal, it extends from the anal verge below up to the dentate line or the pectinate line. As we said, that it is the embryological fusion of the endoderm and ectodermal proctoderm, while the surgical anal canal extends from the anal verge to the upper part of the anal sphincter. Anal canal is defined surgically. This is because when you do an operation for the excision of the rectum, for example anterior perineal resection, you have to preserve the anal sphincter so that you can make anastomosis with the colon or the ileum. There is another line which is called the white line of Hilton, which is a line that differentiates between the skin or the subcutaneous part of the anal canal. The keratinized one is below this line, while non-keratinized one is above it. This zone is called the pectin zone. Pectin zone, it means that a non-keratinized squamous epithelial, the subcutaneous part of the anal canal, while the lower part is a stratified squamous epithelium with a keratinized part. Here the ectoderm is confined about 2/3 of the anal canal, while the endoderm confined to the 1/3. Here is the pectinal line, so that we have two lines, pectinate line or dentate line, that differentiate between the hindgut and the proctoderm, while the white line of Hilton differentiate between keratinized below and non-keratinized above the cutaneous part of the anal canal. As you can see, this is the line of Hilton. Below it the pigmented skin, and above it is non-keratinized or white. Above the pectinate line there is a zone which is called the columnar zone. This columnar zone can be subdivided into two parts. The lower half is called the transitional zone. This is because of mixture of the columnar epithelium and squamous epithelium. In the upper half there is only the columnar epithelium, which is the extension of the mucosa of the rectum. This diagram showing the measurements of the length of the anal canal and the rectum. Here this is the anatomical anal canal up to the dentate line, and here to the surgical anal canal, which is 4 to 5 cm, while the anatomical anal canal is between 2.5 to 3 cm. This is the white line of Hilton. This is the columnar, the column of Morgagni, and this is the sinus, and this is the valve here. Anal canal is divided into two upper and lower zones separated by the pectinate line. Upper zones called zona columnaris. Upper half mucosa is lined by simple columnar cuboidal epithelium, which is red in color. The lower half is called the transitional zone, mixed with simple columnar cuboidal epithelium with stratified squamous epithelium, with its color is a plum. The lower zone is divided into two smaller zones separated by a white line of Hilton, which is the zona hemorrhagica, lined by stratified squamous non-keratinized epithelium, which is white. This is the upper, while the zona cutaneae, it is the lower, lined with stratified squamous keratinized epithelium, which blends with the surrounding perineal skin, which is the normal pigmented skin. As you can see from this diagram, anal mucosa is red in the upper zone. Here anal mucosa is a plum, which is the transitional zone. Here is the anal canal is white because it is non-keratinized, while here the true anal skin pigmented because it is keratinized. And here this is the dentate line, and here it is the line of Hilton. So we can repeat that. This is the columnar cells in the red, this is the upper zone, and this is the transitional zone, the plum color. This is the lower zone. The upper half is white in color. This is the white line of Hilton, and this is the zone of cutaneous, which is the normal pigmented color. And there is a corrugation which is due to the corrugator cutis ani. It is the continuous part from the longitudinal smooth muscle fiber, which is a continuation of the smooth muscle of the rectum. This diagram showing all these zones. Beside that, there is an anal crypt, the sinuses. As we said, that the anal glands secrete mucin secretions for lubrication at the sinus, and then to the valve, the anal valve, to secrete hair around the mucosa. This diagram, this is showing the internal anal sphincter. This is the external anal sphincter. This is the puborectalis, and this is the longitudinal muscle that give it subtation to near round the structures, and this is what's called the corrugator cutis ani. This is the external anal sphincter. As you can see that this is the subcutaneous part, and this is the superficial part that extends behind behind, so that it can unite with the coccyx through the coccygeal body anteriorly with the perineal body. After that, there is the deep part that unite with the puborectalis muscle. Here it make as a sling around to the pubic bone. This is a distinction between the upper and the lower half of the anal canal through the pectinate line. Embryologically, above it is originated from the endoderm, the lower is from the ectoderm. Regarding epithelial surface, above pectinate line is columnar epithelium, while below pectinate line is stratified squamous epithelium, keratinized and non-keratinized. Regarding to the nerve supply, above is from the inferior hypogastric plexus, while below is from inferior rectal nerves. Hemorrhoids classification. Above it arises as an internal hemorrhoids. It is not painful. While below the pectinate line it arises external hemorrhage, which is painful. Regarding lymphatic drainage, the upper half drain to the internal iliac groups, while the lower half to the superficial inguinal lymph nodes, which is below the dentate line, and then to the deep inguinal groups, and then to the internal iliac. Embryological origin. Distinction also in artery. Arterial supply. The lower part, the upper part is from superior rectal artery, while the lower part is from the middle and inferior rectal artery. Regarding the venous drainage. Regarding venous drainage, superior rectal above the pectinate line, superior rectal vein draining into the inferior mesenteric vein and subsequently the hepatic portal system, while below the pectinate line this is through the middle and inferior rectal veins. The middle rectal veins drain to the internal iliac vein, while the inferior rectal vein drains to the internal pudendal vein and then to the internal iliac vein. And as you can see here, this is the venous drainage. This is the anal canal, external rectal venous plexus and internal rectal venous plexus here. The upper half, it is to the internal. This is the to the portosystemic, while the lower half, middle rectal vein, and this is the inferior rectal vein, drain to the internal pudendal vein and then to the internal iliac vein. And as you can see, above the pectinate line, it is drained into the portosystemic system, superior rectal vein, and then to the inferior mesenteric vein. Regarding arterial supply, it is like as the venous drainage. The lower half below the pectinate line comes from the inferior rectal artery, which is a continuation of the internal pudendal, and also from the middle rectal artery, which is a branch from the internal iliac. While the upper half over or above the pectinate line, it comes from the superior rectal artery, which is the continuation of the inferior mesenteric artery. As you know, the diaphragm is the roof of the abdominal cavity. In comparison, in the pelvis, there is a diaphragm of pelvis which is confined to the levator ani muscle. This is the diaphragm of the pelvis, which is confined by the levator ani muscle. This is the puborectalis muscle that makes sling around the rectum, and this is the pubococcygeus muscle, here to the coccyx, and this is the iliococcygeus muscle. This is all levator anal muscle confined the diaphragm of the pelvis. Maintain the pelvic organs and maintain the function of defecation, vaginal delivery, and urination. This is the diagram of the female pelvis from the perineum, that is to say from below. This is the puborectalis muscle surround the rectum. This is the vagina, and this is the urethra. Here is the perineal body, and here is coccygeal body. This is the pubococcygeus muscle, and this is the iliococcygeus muscle. All make the levator anal muscle, which is the diaphragm of the pelvis. This diagram showing the puborectalis muscle surround the anorectal angle, making an 80-degree that maintain the function of the rectum, that is to say continent rectum, that can preserve the fecal material on urge. Any injury to this muscle or weakness, it may cause fecal incontinence. This diagram showing the external sphincter muscle. This is the subcutaneous part. This is the superficial part that joining between the perineal body and the coccygeal body. This is the deep part as confined with the puborectalis that surround the rectum, making it a sling. In a summary, anal canal anatomy. The internal sphincter is composed of circular non-striated involuntary muscle supplied by autonomic nerves. The external sphincter is composed of striated voluntary muscle supplied by the pudendal nerve. Extensions from longitudinal muscle layers support the sphincter complex. The space between sphincter is known as the intersphincteric plane. The superior part of the external sphincter fuses with the puborectalis muscle, which is essential for maintaining the anorectal angle necessary for continence. The lower part of the anal canal is lined by sensitive squamous epithelium. A blood supply to the anal canal is via superior, middle, and inferior rectal vessels. Lymphatic drainage of the lower half of the anal canal goes to the inguinal lymph nodes. Regarding physiology, anal canal function. It serves to lubricate and transmit fecal material as it passes from the rectum to outside the body. It helps regulate defecation and maintain continency, which is voluntary control over fecal discharge. Physiological aspects of the anal sphincters and pelvic floor and special investigations. Anal continence and defecation are highly complex processes that necessitate the structural and functional integrity of the cerebral, autonomic, and enteric nervous systems, the gastrointestinal tract, especially the rectum, and the pelvic floor and anal sphincter complex, any of which may be compromised and lead to disturbances of function of the varying severity. Stages of defecation. Resting tone is the responsible muscle is the internal anal sphincter. Squeezing tone, the responsible muscle is external anal sphincter. Straining tone, the responsible muscle is the puborectalis, and then defecation will occur after that. Clinical examination. Clinical examination of the anals. First, you have to make a proper position, and then inspection, and do digital rectal examination, and then proctoscopy, followed by sigmoidoscopy for the upper diseases. This is the more reliable and suitable position, which is the left lateral position, or called Sims position. This is called knee elbow position or jackknife position. This is called lithotomy position. Digital rectal examination. This is a digital rectal examination. You have to do it under aseptic technique. You wear gloves and you take a permission from the patient and make the privacy and do the proper position, which is the Sims position. Then you put a xylocaine in the finger and make a gentle massage on the anal verge, and then insert your finger as a warlord round movement, and then you have to feel the mucosa, the fixity of the mucosa, if there is any mass or there is an impacted feces. By the way, you can feel the posterior wall of the prostate in male and the adnexia in female. After that, you withdraw your finger and look if there is a mucus or feces or bleeding or clots or pus. This is a proctoscopy that you can use it to inspect the anal canal and the lower part of the rectum by the guide of light, and you can take a biopsy if you need it. Investigations. You can order for endoluminal ultrasonography, anal manometry, EMG study, dynamic magnetoresonance proctography. This is an endoluminal ultrasound. This is the probe inside the anal canal. This is anterior, posterior, left and right. This is the picture of the anal canal. This is from the inner to the outer. Interface, it is hyperechoic. Mucosa is hypoechoic. Submucosa is hyperechoic. Muscularis propria hypoechoic, and perirectal fat is hyperechoic. And if there is any abnormal lesion, for example a mass, to the intraluminal or intramural or extramural can be detected. This is a manometry of the anal canal and rectum that can measure the anal sphincter pressure and record it on a diagram. This is the rectal pressure and this is the anal pressure. This is at the squeeze stage. As you can see here, increase the pressure of the anal canal and plotted as diagram. This is an EMG study that studied the nerve conduct study and the muscle power. This is the magnetic resonant defocogram. The fluid inside the rectum plays as an contrast. This is the normal. Here it is the resting pressure, normal, and here it is squeezing with mild elevation of the rectum. Here it is straining, so that there is a change in the anorectal angle and hence passing of the flatus, the flatus and the fecal material. Here is abnormal anorectal angle, and you can see there is an incontinence from the beginning, and the patient cannot control his pelvic contraction. This is the end of the first part of the lecture. Thanks a lot.